I'd like to expand a little bit more in terms of the future of mapping, and I wanted to actually share some research that's been done, much of it in collaboration actually with Professor Hasseger's lab, and we're actually quite excited about it. I'll just jump right in here. When we are mapping, as most people have done in the lab, there are actually a number of trade-offs, but one key trade-off is this notion of the field of view that you can reach. Just like Professor Hasseger speaking of the body surface approach, you have a wide field of view, which is very helpful to see things simultaneously. At the same time, most of us are familiar with being very proximal to the source. When we are mapping, we're mapping typically in a point-by-point fashion, and we have an electrode right on that tissue, and we're very confident of the signal that we're taking. So we'll just talk a little bit about this traditional point-by-point mapping, where it fits in. I want to talk a little bit about another approach. Many of you are aware of the non-contact intercavitary mapping, a lot like the body surface, except you're inside the chamber. And then what I want to do is expand into some other hybrid options that are coming about. The notion of giving you higher density in your maps with multi-electrode mapping, and where that fits on this spectrum. Again, this is probably an important table that I'll keep referring to, and that is, on this axis, you're getting closer to the source, and your field of view is smaller. On this axis, your field of view is larger, but you're further away from the source, and here you have the representative 12 lead, a very global view of things. I'm going to finish up by talking about this notion of wide field mapping, an idea that can we have the best of both worlds? Can we be fairly proximal to the source, but also get a very broad view of what's going on? Okay, first a little bit a review of traditional point-by-point mapping. Advantages: very high confidence. Disadvantage: we all know that it's a little bit time-consuming. Typically you may map 150 points, and maybe you take 20 or 30 minutes to make a full global or chamber map. And you end up with the spatial resolution. The number of map points is, again, a little bit limited. We know it's very useful. It's a very fundamental part of the EP procedure today, useful in conjunction with other maneuvers, such as pacing maneuvers. Okay, just briefly, talk about this non-contact mapping. And we can see that this is a little bit of a hybrid on the spectrum. We're inside of the chamber, but we're not necessarily in contact with the tissue. Okay, so advantages of this method: very rapidly, within a single beat, we can see different events, just like Professor Hasseger is describing with the body surface mapping, something non-sustained or disorganized like AFib. That's a good thing. We know we can acquire that map very rapidly, almost instantaneously. We aren't always sure about the resolution that we're receiving. There are dependencies that I'll talk more about. How close are those recording electrodes to the source of your signal? And do you have other structures that are in the way that might be preventing you from seeing what you really want to see? This is when it works well. This is a simple, organized rhythm, focal atrial tachycardia. The array, 64 electrodes, is inside of the center of the chamber, and it gives us a really nice idea here of where the source of this atrial tachycardia is coming from. This is actually, I'm sorry you can't see the bottom here. It's a kind of a nice classic case coming from Dr. Young-Hoon Kim in Korea back in 2002, I believe, he put the array in the left atrium. We make our geometry, looking for the onset, spontaneous onset of atrial fibrillation. And actually, this is from the early virtual electrogram just here. And we can locate that site. Of course, that's 10 years ago, and now much has changed in terms of PV isolation, but it's just showing you some of the utility. Okay, how about the limitations? Well, when we are close to an area of interest, when the array is nearby the His bundle, for example, you can actually see quite nicely. These are the virtual recordings reconstructed, and you can actually see that small, that His bundle region. The issue is when conduction moves further afield from your recording electrodes, you really are losing the resolution. And if you're going to lose resolution, I think you as physicians, it's very important that you know that. You need to know what is your confidence in the quality of the mapping that you're getting. Okay, now I want to shift a little bit on this spectrum and pull back just a little bit. Instead of talking about the attempt to go for a global chamber map, let's look at a regional map. And now this is this is what I'm going to be talking about, the idea of multi-electrode catheters and basically taking points simultaneously, achieving high density and certainly a larger field of view than you could get with a single point map. Okay, I talk a little bit about the clinical utility of this technique. I want to also just share some of the interesting research that this high-density regional mapping has enabled in the recent couple of years. And then I want to just share a couple of the potential developmental algorithms and some of the things that we think might be important for automating some new types of maps using this regional mapping. So this is kind of a funny picture. This is actually showing a left atrial tachycardia, and it has been mapped with a 20-pole, this mapping catheter here. So you can see quite high density. We don't have a geometry here. But anyway, it impresses you with the number of points that you took. Okay, some more details. I'm going to share with you now, this is from maybe a few years ago with Dr. Reddy and colleagues. They looked at a series of about 19 patients post-PVI atrial tachycardia and investigated using this high-density mapping to map the tachycardias or flutters. These were some of the results that they had. The efficiency, the time it took to create this full map, on average 8 minutes. That's about 1 point per second. The resolution of the maps, 558 points on average, and 2.6 points per squared centimeter. So certainly, and you'll see some examples of this. Better resolution, we have to believe, leads to increased efficacy, being able to see critical pathways and such. One question about this technique is the adequacy of the contact of the electrodes. If you're mapping with a single ablation catheter, the physician can be maybe more confident that you have contact and you can look at that electrogram. How do we manage that with multi-electrode technique? I will get into that a little bit here in just a moment. First, I want to share with you a tale of 2 different flutters from this case series from Dr. Reddy and colleagues. The first one is coming from Prague, and it's basically, this is a post-PVI left atrial flutter. We'll diagnose it in just a moment. The second one is the same thing. It's another post-PVI flutter, again mapped in high density with the 20-pole spiral catheter. So this is just a little animation showing you the process of taking the points. Many of maybe many in the audience have actually used this technique, but it's very rapid. You can see we're going to take 100 points in about 20 seconds for this slide, and we're building up the activation map here. Okay, so in 20 seconds, we can just, we already know a lot of what's going on. We can see that there's low to high conduction, and then we also have a counterclockwise conduction going around the mitral valve. This is some of the statistics for this map, very rapidly taken. And this was the map that we ended up with. Kind of an interesting, you can follow the isochrones, and you can see counterclockwise conduction and an area of slow conducting here. But what's funny is this purple blue color should be followed by this pink or this white color. And there's a jump. So we're not seeing a continuous conduction, at least on the endocardium. Well, this was kind of a neat example because now what I've done is we now add the coronary sinus as a part of the map, and we're mapping also with the coronary sinus catheter. And if you follow here, just follow the blue wavefront, or maybe the white one, you can see how it's jumping over to the coronary sinus before it lands just there where the white, white goes from here to here. So what they did, and maybe you can imagine this, they tried their standard perimitral isthmus line endocardially, but it wasn't making much of a change. And I think 3 or 4 lesions after that, then they move into the coronary sinus. First lesion at this location, this critical location, termination. Okay, so it's just a neat example. Maybe we've all seen these kinds of things, but it's what I want to impress upon you is the utility of having a detailed map, even for these simple or organized rhythms. Flutter number 2. Okay, so now again, post-PVI, atrial tachycardia or flutter, and we can see very quickly we have conduction up the posterior wall and then coming back. It's up over the roof and then coming back down. Here's the animation. So we're very interested in this roof conduction, what's going on up there. So we're going to look at a couple of things. During the flutter, we can see interesting long fractionated potentials, a nice little gradient from distal to proximal. It looks very, very good. Then we try some entrainment maneuvers, and we have very good entrainment at that same location. So we're going to ablate here. And first lesion, we can terminate that roof flutter. So the question is, there are many ways to terminate these kinds of organized rhythms, but can we do it with a minimal lesion set? Well, I'll expand on this by asking the same question regarding the ablation for AFib once the veins have been isolated. Okay, how about your confidence in terms of contact when you're using this type of an approach, multi-electrode approach? Okay, partial contact here, we can see that even though much of the catheter is not in contact, we can see only a few of the electrodes are actually projecting on the map, and that's because we have an interior projection distance control here that basically rejects points that are a given distance away from that tissue. Okay? Here's kind of an example of that. This interior projection criteria, currently I have it set at 10 millimeters. So any points on this activation map that were taken within 10 millimeters of surface, they are projecting. Let's bring it down to 9 millimeters, or 8, 7. We start to lose some points. If I go down to 5 millimeters, my map is becoming less dense, but perhaps I'm having a little more confidence in the result. Okay? Okay, so next I'd like to highlight a couple of the research initiatives with the HD mapping technique. And the first is actually coming out of Professor Hasegaer's lab. It's actually some recent work done combining HD mapping and MRI image integration to get a better look at how the AF function relates to the structure of the left atrium. So what we did for methods here is, first of all, the MRI scan is made pre-procedure, quite high resolution. We are going to segment not only the anatomy of the chamber, but also the region of brightness or the delayed enhancement, and that is done here. And so that ends up getting segmented back into the 3D model. So our 3D model will have the chamber plus any of this delayed enhancement. It will then be imported into the mapping system. Then what we'll do is we want to quantify the surface area of the compact or the dense delayed enhancement and compare that to the non-delayed enhanced regions. We're going to register this model with our electrical map. The electrical map that is created is actually a map looking at fractionation. It's using the CFE map, and these bright areas here are areas where we basically are cataloging electrogram fractionation. We want to compare these regions with the delayed enhancement. Where is the fractionation being found? At a glance, you can see some of the patients that were looked at, the CFE map being below this area of high fractionation, and then the delayed enhancement above. And this is 4 different patients. There are more of them. But you might already get to notice what we were noticing, which is the fractionation looks like it's happening where we don't have the delayed enhancement. Let's take a look at some typical electrograms on one of these patients. So in an area where we have no delayed enhancement, no fibrosis, we can see very continuous fractionated activity. When we get to kind of a border zone or an area like just along the edge of the fibrosis, it's more of an intermittent activity. And then when we go right into the center of this delayed enhancement fibrosis, very organized activity, long cycle lengths. Okay, so this is about 1/3 of the chamber is going to be the fractionated activity, and about 14% of the chamber on average was the delayed enhancement. I think a key result from this is that when we look at each of the surfaces, the compact or the mid delayed enhancement or the non-delayed enhancement, it's the compact delayed enhancement that has basically less fractionation, whereas the other surfaces have actually more fractionation. It's just another way of looking at it. I'm going to skip through some of this, I believe. Okay. One other thing I wanted to share with you in terms of this high-density mapping research. This is coming from Dr. Davila back when he was in Miami. That's Andre Davila. But did a series of about 10 post-PVI persistent AFib.
Dr. Kim, could you move to high-density information and finish in 2 minutes?
2 minutes. Oh, boy. Okay. I'm going to skip this one. All right, let's I apologize. Let's move to one other area. Looking at some regional wavefront dynamics. Okay. Yes, talk about the mapping of AFib itself. And these electrograms being quite fractionated, what we really want to see is the activation, the local activity wavefronts, and this fractionation is not really representing that. So we're going to process these signals, filter them down, or even go with the unipolar recordings that will give us a clearer view of local activation. And we're going to take this same series of patients and look at some of the wavefront propagation. So during atrial fibrillation, we can see, interestingly, conduction moving around this area of delayed enhancement. But it doesn't do that every beat. Here's another beat where we can see there's actually a conduction block, and it's a bit out of sync there. I'll skip to another one. This is actually now pivoting again around the area of delayed enhancement. Remember, that region was a bit organized, and now we can follow the conduction going around that area. And then I will finish by talking about some of the algorithms that we could employ that will actually make this more of an automated type of an observation, maybe a little bit less subjective. The idea is, can we build onto the foundation of electrogram morphology analysis a higher level syntax, the syntax of spatial pattern analysis? If we can do that, then there are different algorithms that we could employ, such as looking at absolute activation in real time. We could look at real-time propagation vectors, wavefront pattern detection. We could catalog the patterns of collisions happening on the map, etc. So this is part of a development platform that my colleagues at St. Jude are currently working on. They register a 3D catheter in space, and they have the multiple electrograms. Then they will superimpose that onto a 2D template, and then all activity is now being detected, and it will allow it will allow the depiction of the activation wavefront along with vector information, here being the vectors. And you can see here in real time. Do I have time for 1 minute? Thank you. Okay. Part of the future, we believe, is being able to map a wider field, even wider than the field that I showed you. So the idea of more of a sector mapping. Okay, and one thing that we are working on in St. Jude is the next generation of the non-contact mapping. It's basically a maneuverable catheter, a basket catheter concept, and it will allow you to do the same that you could do before, which is the single beat global map, but also wide field regional mapping, and also even contact mapping. Here's an example of a contact map taken from the animal studies that we're currently doing with this prototype, voltage map, high density, but it's fairly conventional contact. Here you see the global single beat map that's giving us an idea of the source of interest, but it's not very high resolution. But then we can move the catheter in nearby to the area of interest, and we get a very large region of detail. If you want even more detail, we go into contact mode. We have a little bit smaller view here. And ultimately, I think the thing that would make sense is a hybrid map. So we would actually be able to present you the region of contact with all of that detail, along with the global non-contact, what's happening all around the chamber. Thank you for your patience.